Hi everyone. Today we will be discussing diabetes medications, in particular metformin. Metformin belongs to the biguanide class of medications. Biguanides are a class of glucose-lowering agents derived from guanidine, and metformin is the only drug from this group currently in clinical use. The reason being, the other agents in this class have been very strongly associated with lactic acidosis, which is one of the complications that we will be discussing later on in the lecture. Metformin typically is the first-line pharmacological treatment for most individuals with type 2 diabetes mellitus. If you look at most clinical guidelines across the world, you'll find that metformin typically is the first agent initiated in patients with diabetes. The origin of biguanides can be traced back to the use of the plant Gallagher officinalis, commonly known as goat's root or French lilac, which is rich in guanidine compounds. Now, how does it work? Well, it works through three principal mechanisms: enhancement of glucose uptake and glycogen storage in skeletal muscle and adipose tissue, inhibition of hepatic gluconeogenesis and glycogen breakdown, and finally, reduced intestinal glucose absorption. Metformin is associated with weight maintenance or even modest weight loss and appetite suppression and provides cardiovascular benefit. A bit on the pharmacology, metformin exerts its effects through a combination of insulin-dependent and independent pathways. One key mechanism involves activation of AMP-activated protein kinase, an intracellular energy regulator that is typically stimulated during exercise or hypoxic states. Activation of AMPK increases the expression of glucose transporters and promotes cellular glucose uptake. When used as monotherapy, metformin lowers fasting plasma glucose by approximately 2 to 4 millimoles or 36 to 72 milligrams per deciliter, corresponding to a reduction in HbA1c of around 11 to 22 millimoles or 1 to 2%. Metformin can be used alone or in combination with other oral glucose-lowering agents or injectable therapies. So generally how it goes is that metformin is initiated as monotherapy. If this is inadequate to control blood sugar, dual therapy will be started with two agents. And if this is inadequate to control blood sugar, then triple therapy can be used to control the patient's diabetes. Now, if this fails, the physician may consider starting insulin at this point. Metformin is generally well tolerated, does not promote weight gain, and carries a low risk of hypoglycemia, unlike other classes of medications like the sulfonylureas like gliclazide. Gastrointestinal adverse effects, including diarrhea, abdominal discomfort, and nausea, occur in around 10 to 20% of patients, but are less common with gradual uptitration or modified release formulations. So, for example, your doctor may start you on metformin 500 milligrams once a day for about a 2-week period, and then titrate you to 500 milligrams twice a day in an attempt to reduce some of these gastrointestinal side effects. The most serious potential adverse effect is lactic acidosis, which, although rare, can be life-threatening. Metformin increases lactate production, and lactic acidosis may occur in situations where lactate clearance is reduced or anaerobic metabolism is increased, such as in shock. So for example, if you are on metformin and you present to hospital with an acute illness, oftentimes your physician may stop metformin and cover you with insulin injections once you're in hospital. Consequently, metformin is contraindicated in patients with significant renal impairment or liver disease. It should not be initiated in individuals with an estimated glomerular filtration rate below 45 and must be discontinued if eGFR falls below 30. Patients should be advised to withhold metformin during episodes of severe acute illness, dehydration, or persistent vomiting, during surgery, and for 48 hours following imaging studies involving iodinated contrast. Metformin should also be avoided in individuals with a history of excessive alcohol use. Finally, metformin interferes with gastrointestinal absorption of vitamin B12 and may lead to deficiency, though clinically significant anemia is fairly uncommon, and as such, routine monitoring is not recommended unless deficiency is suspected clinically. For example, if a patient complains of fatigue, dizziness, palpitations, and so on. What you would do is a complete blood count, and you would look for the typical findings of B12 anemia, which is a macrocytic anemia.